So, starting with, we've got a new trial with Orforglipron that was just published. This is called the ACHIEVE-3 trial. We had previously heard top line results, but Orforglipron is actually a non peptide GLP-1 agonist. And as a reminder, what that means is that it doesn't have the same restrictions that the semaglutide oral has in terms of it doesn't get degraded so quickly by the body, and we don't have to separate it from food, from drinks, from other pills. It can be taken once a day with all of those other types of things. So it actually went head to head though versus oral semaglutide. And Natalie, you want to share a little bit about this trial and what happens?
Sure. So the Lancet published the results from this phase 3, right? Phase 3 is a good thing. Achieve 3 trial that had 1,698 patients, and it was head to head, which is daring because you don't always know if you're going to actually, end up in a better position or not, right? Is it going to be inferior? Is it going to be equal? Or is it going to be superior, right? So they looked at people already taking metformin, achieved mean A1C reductions of 1.7 and 1.9 on the 12 and 36 milligrams of the orforglipron, and respectively. This compared to 1.2 and 1.5 on the oral semaglutide, 7 and 14 milligrams. So it was superior, which is pretty amazing, actually. All primary non-inferior comparisons were met with both orforglipron doses, showing non-inferiority to both semaglutide doses. So, what do we say about that? The side effect profile. You go, okay, we see a little more. We see a higher A1C reduction. We see, right? We'll start looking at weight to go with this. There was more GI side effects with the orforglipron, which I think is interesting, right? Substantially more at 59 and 58% on the 12 and 36 milligram doses. So, respectively, compared with 37 and 45 milligrams on semaglutide, 7 and 14. That is significant, Diana. What did you think when you read those? Because I was like, whoa, that's a lot of GI.
Yeah, well, it begs the question kind of the dose titration. Um, because I would like to know a little bit more, I guess, of when they lump the side effects together, is it just when the dose is initially started or when it's increased versus long term? Do people tolerate it better? I mean, certainly, though, that's an important consideration. If people don't tolerate it as well, then even if it has more glucose lowering and more weight loss, that's not going to be something that everyone is going to want to have. So,
Absolutely. Right. And that's just the point. It's kind of like there's never going to be one drug for everyone. Right. I love that idea of just, okay, but that means people didn't have nausea or GI side effects, and those people are going to do very well on it. Right. So, I think that is interesting, though, that it was significant enough that, what do we do? I mean, I typically give a little bit of, um, Zofran, right? Sublingual, um, to people who struggle when the dose titrates up. And so we're going to have to dive a little bit deeper into this. Is it all the time? Is it just for the first few days of titration? And we need to remember always in trials, they ask if you've had nausea. And even if you report it one time, it's considered that you've had nausea, right? So that is always should be in the back of our heads as we look at these trials, that we ask when it's not a I had it 50% of the time or more, or I had it for 3 days or more. It's literally if you report it once, it's reportable, and so that's always my thought when we're looking at trial data.
right. I think also overall, the discontinuation rates related to GI side effects were not very large. So it was 6% in the orforglipron group versus 3% in the oral semaglutide group. So, yes, it is greater, but overall, most people did stay in the trial. So I think that is very encouraging. Um,
Yes, I
so,
agree. Right? So even if you have nausea, is it severe enough that you had to stop it or not? And again, 3 to 6% is double, but it's still a low number overall.
right. So I think that is good. Um, and we know there's different things we can do to kind of help people get through this. There's other drugs that we can prescribe, at least in that initial time period, if they're having nausea or vomiting or they're having diarrhea or constipation. But it definitely is interesting that there's more suggesting that maybe some of it is related to its potency, right? It's more effective, but also it may be, yeah, have more side effects as well.
Absolutely. And as we say with all of these trials, guess what we're going to say here? More to come, right? I mean, this is, it makes me start to look at the meetings that we're going to be attending this year. What are we going to see at ADA read out? Where are we going to, what does approval look like? Those kinds of things. And so because this is a phase 3 trial, are we going to get it before the end of the year?
Yeah,
Exciting.
well, supposedly it's been actually submitted to regulators in 40 countries, over 40 countries, including the US, where it's expected to have an action in the second half of the year.
Yeah.
I think
Fall.
the original indication they're pursuing is going to be for obesity. But very, very interesting. I mean, I am kind of blown away the fact that the higher doses, the 36 milligrams, had that 2.2% A1C lowering versus the 1.4 with the 14 milligrams semaglutide. Of course, there is going to be a higher dose. There already is a higher dose. There's the 25 milligrams of semaglutide. So it didn't go head to head with that. So that, of course, is a limitation of it. So we don't know how those compare. But yeah, you're exactly right. More to come. I do think this would be a really nice option to have. I think especially the oral semaglutide, now that it's kind of been renamed. So for obesity, it's just the oral Wegovy, and now for diabetes, there's going to be the oral Ozempic. And I think that name recognition is really helping people and encouraging people like, "Hey, I wanted to do the oral," versus when it was just called Rybelsus. I think there was a lot of like, "Oh, I don't know what this is. I don't know if I want to use it
Absolutely.
or not."
I
So
mean,
any
Ozempic has done a very good job or Novo Nordisk has done a great job of name branding the efficacy of Ozempic, right? And the other indications with, all the other benefits that we've talked about over the last year or so, right? Like, or 2 years now, even, right? With osteoarthritis, with MASLD, with the flow trial, right? And every time they've come back out and said, this is semaglutide, this is Ozempic, this is, right, Wegovy, this is reduction in cardiovascular risk, this is, right. So now I've never had a person come in and say, I would like Rybelsus, ever. But I do have people now coming in to say, I heard Ozempic comes in a pill now, right? And amazingly quickly, too. I mean, within weeks of it happening, I'm now having people come in and ask for it by name as a pill. So that's very interesting to me.
Yeah, the oral Wegovy,
Yep.
is
Yep.
available now. The other the
Oral
last
Wegovy. Yeah.
sad the last thing I wanna just touch upon, though, is of course, the cardiovascular outcome data, which we don't have for Orforglipron. We don't
Right.
have it resulted. We don't know how that will play out, and I do think that's a very important consideration. So oral semaglutide has been studied, and based on the, SOUL trial, it does have the indication for cardiovascular disease, and in fact, based on the positive data also in SELECT, even the version for weight management also has the cardiovascular
Yes.
indication. So certainly for one that has cardiovascular disease, even if orforglipron is more potent, I think we just don't know yet how that will play out with the molecule, and we have certainly been burned with other molecules in the past. Even weight and glucose is certainly a surrogate outcome, right? So we wanna see the cardiovascular outcome data. I know eventually we will have that, but that may be another reason to kind of distinguish the 2 if they're both available.
Absolutely. When you go to pick what is, yeah, absolutely. We need to be careful and stick to, I mean, there's a what is the most important, and people with diabetes have a higher, people with overweight and obese as part of their co-diagnoses, depending on who we're seeing in front of us, all have a higher risk of cardiovascular disease, right? So That is, do you already have it? Is it your parents? Is it your brother? Is it those all increase your risk? And are you going to use a molecule that has proven efficacy in that? We do here at our practice, absolutely.